I had my initial exposure in Kiel in 1993. So I and Anupama have a connect, and I was a fan of Professor Mettler, and at the time she was doing a lot of endoscopic work, and at the time SEM was live, and at the time she was also doing a lot of endometriosis work. And Kiel is a place of life and a place which are open to sharing their knowledge. I feel it was a great privilege for me to go there, and the most important thing is they didn't even charge even 1 rupee for me for my course of 6 months. Then I went repeatedly again. Then subsequently Hans Tinyberg from Bielefeld, which also happens to be Mamta's close friend, was also mentoring me for many years. The fascinating I liked about Germany is their willingness to share knowledge in an unconditional way, irrespective of our color of our skin. That's what fascinated me. Six. Dim lights. Lights, because you're dim. I thank all of you for the patient hearing, and in spite of the delay, all of us are actively participating. I apologize for being a chairman and running the show late. And in this lecture, I'll be basically giving you a journey which I'm experiencing in the area of uninterrupted culture systems to maximize embryo culture system. And it's a path where, for a gynecologist, it's unconventional and never thought about. Whereas, since I had some amount of exposure and some amount of spindle exposure, and at the cell level, this keeps on fascinating me. And my colleague Dr. Madan always keeps on teaching me and encouraging me to read certain other areas which help me to make both right and wrong decisions. When you look at the technologies that have happened or the major breakthroughs in the area of assisted reproduction, the first was the IVF, the second was the ICSI and the testicular sperm extraction, the third is the vitrification. All three changed the lives of our patients. I'm not sure at this moment, well, time-lapse might change that, but my gut feeling is it may. But only time will tell that. And I'll try to explain why I feel it may have some relevance in relation to this slide, but only time will tell that prediction. We all feel time-lapse imaging is a new technology, and it has been 200 years of effort to see the embryos. And innovation in technology has helped us to visualize the embryo as they are, and now without disturbing them. Earlier, you have to disturb them to see them. Now you are able to see them without disturbance. That is one step ahead for the bigger thing. I was fascinated with this article in the Science where they're given time-lapse of embryology in the mammalian kingdom, and the fascinating aspect is it dates 1818, and the first time-lapse movies of embryos were made in 1907, and now we are in 2019. Maybe we were not aware of the technology, or the industry felt the need was not there, or the technology and the integration of the industry did not happen hand in hand, because an old technology has moved into the lab quite late. And in this journey, we have moved through different incubators. When you look at the timeline of IVF, it's similar to the timeline of Apple computers. And as the computing speed increased in the last 40 years, and as phones have become as powerful as the mainframe computers today, you see the same change repeating in today's field of embryology. We had an early attempt of time-lapse, where at that time, in 2006, we had an incubator built around an inverted microscope, and then tried to study time-lapse imaging, because we are always curious. And the limitations of this is you can only handle one embryo or one oocyte. And then this is the thing. And I could retrieve the footage of that thing, wherein today's time-lapsing and time-lapse imaging as a photography a decade back are radically different. Here in the time-lapse, you are only seeing the movement of the cell, and to a little extent the movement of the blastomere. The movement on the holding pipette is when the embryologist comes back the next day to see, they're adjusting and focusing. So you see the fluid in the holding pipette coming and out in this thing. Here you see fragmentation forming, and it was more a curiosity and uncertainty what does mean at that time. But as time went by, and as the first time-lapse incubator was built in 2008, subsequently commercially launched in few places in the world in 2011, but entered the mainframe to a little extent in 2015. That's the reason you're seeing the publications increasing in the last few years. The first incubator in which Louis was born was a flask, and we have moved so much so far in the last 40 years. The principles are the same, the modalities have changed, the precautions have changed, as IVF has become a research treatment to an everyday common treatment. So technology in all aspects of IVF have improved by leaps and bounds in the last 40 years. After those incubators with the glass flask, then the cell culture incubators were brought in, and then they were used as an incubator. They have their own advantages and disadvantages. They are no way inferior to any product. Each product has a certain positive features and a negative features. And these incubators were designed initially for cell culture and flasks. The only drawback is the recovery time of the gases is longer compared to the other modalities that are present today. To overcome that, a group of researchers or embryologists or scientists, whatever you say, have developed the MINC incubator in Australia, which was exactly designed for an IVF condition, minimizing the space, minimizing the recovery rate, and all benchtop incubators follow the same principle of reducing the space, improving the recovery, so that the embryo is not into a harmful environment. And so the MINC incubators had better temperature control because of faster recovery and smaller spaces. When we are looking at evaluation of the embryos, the guidelines say so many things. We look at so many things. We look at pronuclear alignment, stage-specific assessment, fragmentation, multinucleation, blastocyst expansion. If you are going for a blastocyst culture, inner cell mass size and proctodon, and also the physical appearance from time to time. All these involve proper documentation and time. If you look at the minimum number of times one opens the door, can be at the most minimum is 3, and it can extend to 7, or it can extend if you are using many dishes to a triple digit. So that has impacted, but none of the studies or none of the work which published this is the implantation of this protocol will never say what type of incubator systems are used and how many times they are improved, and whether they are measuring equals and equals, which an embryologist knows, where the clinician may not talk to the embryologist. And that's when the time-lapse are there. There are 3-4 models in the market. There's nothing called a perfect model. You have to choose what you feel which is relevant to your own situation, and each has its own benefits. And when we looked at the choice of choosing a time-lapse imaging, we felt there will be better conditioning of the pH because we are not opening the doors. We'll have better selection because we have a huge amount of database of the patient, because each embryo might be photographed every 5 minutes, and on all the 12 to 16 oocytes which are kept, or all of them are photographed. You have both inter and intra performance of your embryos to judge the conditions. And of late the publications are coming in, the prediction of aneuploidy and the prediction of blastocyst formation and the quality control. These literature articles, I felt maybe there's a future in upgrading to this technology. It's a combination of a technology, imaging, and artificial intelligence. It's not a single imaging modality. They are using the databases and constantly refining that information. The technology is multiple cameras and smaller size, and multiple parameters apart from photography being integrated into the incubator is what is making a game changer possibly in time-lapse. But even though I put the image of this product, it applies to all time-lapse incubators, and each has its own advantage. Thereof, time-lapse is already entered. That's what some of the Europeans and Americans feel. But it's a situation that you can't, nobody can say if a lab does not have a time-lapse, it's not inferior in any way. But if there is a technology, we move with time, like how we move with our mobile phones. It does not mean the older mobile phone does not work. We want more functions, more information, and more control on our lives and our situations we deal with. That's the change in the attitude we are bringing to ourselves in the last 1 decade. So is it better conditions only, or is it a fascination of photography compiled together? Is there a science behind that? I'll be speaking about the science behind that, which I've learned in the past 6 months. In a normal time-lapse imaging, here are the chambers that are there. Here are the chambers on which all the oocytes are kept in, and one chamber is for one patient. And here is the timeline in hours, and here are the events that are marked. Here you are seeing the changes that are happening. Here you are seeing the appearance of the, can I off the lights please? Here you are appearance of the 2 pronuclei, and then you try to correlate the pronuclei with the timeline. Lights off. Then with time you'll also look at disappearance of those 2 pronuclei and the first cell division. Here is the disappearance is happening. Then the next step is the division, which you will see. here is the line. Here at particular, sorry. Here you are seeing the cell dividing. Sorry, I apologize. Can I have my laptop because this graphic processing is running slow? My laptop is slow. Yeah, this is the keep it like it takes the thing. Yeah, it's working. So you see the cell dividing, and then these are the markers. You see the two cell. Then it started dividing into the 4-cell stage, and there are specific timelines for each of these, but they differ on the culture condition and the model that is available. There's small deviations. Then you find the next set of cell divisions that's happening. There in this technology, you'll be able to review what is happening, and you'll also look at changes that have happened at each blastomere level with time. This is facilitating to understand oocyte embryo in a much better way. So here you see a large gap. If the embryologist looks at here, he'll say the embryo is delayed. If they look at here, again, if the timing is not right and they have 5 or 6 oocytes and 5 or 6 cases, and they don't mention the time, they might find there's a delay. This embryo is turning out into a good blastocyst with a very, very few small minor deficiencies. So the application also gives you a marking, or you can do your own self-defined algorithms with time so that you'll be able to integrate your own system. Here it's now in the compacted stage, day 4, and then it's look at the cell division, which we never imagined such things will happen. Then the cavity formation is happening in, and a small vacuole has been found but self-corrected. And the blastoma is trying to expand. There's also information saying number of times it tries to expand will also have an impact on the embryo. Here it's showing an adequate inner cell mass. See that expansion and deflation. There are also publications saying that's also resolved to a physiological mechanism. The significance at this moment is not known for that. Here is data as early as 2010 by P.C. Wong, the duration of the first cell division and the embryo assessment. The other thing is, how good is the sensitivity and the specificity of the blastocyst prediction using the first 48 hours? The sensitivity is reasonably good, but the specificity is very high. That's a major thing, and by having a high amount of specificity, you are able to deselect the embryos rather than select an embryo. You can eliminate these embryos will not give a pregnancy or reduce chance, and select the best possible embryos. And with time, there is also data coming in that a selected embryo which looks equal in a normal photograph, by using time-lapse, it is giving a higher implantation per embryo transfer, but not an egg retrieval, and a 36% reduction in the pregnancy loss, because you are eliminating triple cell division, reverse cleaving, and also vacuole formation before you are transferring the embryos. Recently, earlier there were a couple of papers saying relation of time-lapse imaging to the aneuploidy and euploidy, but in 2008 there was a comprehensive review of literature predicting the morphometric parameters of embryo polity status, which was published, which showing interesting insights that in future a combination of time-lapse and aneuploidy screen will make a difference, because right now aneuploidy screen is giving a 50% chance of a live birth. Maybe a combination of time-lapse with aneuploidy will move that benchmark another 10 to 15%. So the second thing is a new word called trichomatous cell division. Here what happens is the cell, instead of doing into two cells, sometimes divides into a third cell. Here the polar body was not excluded and it became the third cell. Normally we think that the polar body is behind and we missed it. And here you are also seeing the appearance of a possible third pronuclei. You have seen that, which is an aberration, which we miss when we don't use a time lapse. So the more importance is not the selection, the deselection of an abnormal embryo, which will help us to look beyond embryology. Most of the time when the patient asks, why didn't the embryo did not implant, we say the embryos are excellent. But when with this information input, we have further information and insights which tells us that if you have perfect embryos, what happens is, and you don't get an implantation, then you look into the uterine cavity and looking to work on the immunological factor. That's again a huge field. Till now we did not have conviction to say the embryo is good and then looked into that. That's the game changer that's going to happen. In this video, which again I added of the same video, but when you see at the end of 96 hours, it looks like a reasonably satisfactory embryo, but in reality it's not a good embryo. So it became a 4-cell later, it became a multiple cell. But what we missed here is the 3 pronuclei that has come, and the polar body was not extruded. So there, that's what we might find out if we do an aneuploidy screen. It's an abnormal embryo. But here it's a tool which might help us to eliminate it. And there's an interesting concept called reverse cleavage. That means a cell divides into 2 cells, then goes into 4 cells. Sometimes it reverts back into 2 cells. That's when embryologists will fight. One says you missed 2-cell embryo and thought 4th cell. But there's actually a phenomena where the cell undergoes reversing. Here we might miss these vacuolations, and here that's where the cell is divided into 2 cells, but again it starts dividing as if it's a 2-cell. So that we miss and then think things are fine. If you are doing a 2-cell embryo transfer, day 2 transfer, like some countries in Germany, I'm not sure whether the law has changed, because they don't allow an embryo to be transferred beyond 48 hours. Whereas in other countries, they're allowed for 5 days in Europe. So they might be making a mistake here and picking up the wrong embryo. The emphasis of predicting the embryo early, because people are moving to lesser a number of days of embryo outside the incubator, so that it reduces the stress and the unknown factors we are exposing them to the embryo. Here you are seeing a slow cleaving embryo with a fragmentation. A 2 pronuclei with less number of nuclei is again an indicator. And sometimes this is the mess we create to the humankind, which is beyond our control. And till now, none of us are aware of these physiological changes and did not give any importance to the physiological changes. So these will open a new horizon of the way we look at embryo and where we look at IVF failure. Here you see an interesting thing where you have a normal cell division. At whichever time the embryologist is supposed to see as per guidelines, it matches the quality of a perfect embryo, except after some time it starts developing vacuole and then pushes the other blastomeres to a side. And if you are not careful, if your microscope is not good, you might think it's a blastocyst. These are the chambers of one patient, so there is no mix-up. Each incubator comes with 6 chambers, so it will be valid for 6 patients. For this model, I am not aware of the other models, how many chambers will be there in each of the chamber, but the Gary has 6 chambers, means it's valid for 6 patients. So you see the cell division. I'll just forward it because of the time issue. You're seeing a vacillation evolving. If you do a day 2 or day 3 transfer, you'll vouch that it's a good embryo and then think we missed somewhere. It will also begin the trend of reducing the number of embryos because you have better quality information. Till now we did not have this quality of information, so we are not comfortable in reducing the number of embryos. With time, here I would consider it may not be a good embryo because of the changes. If you only see the events, it says perfect embryo. Then we tell the patient that you had a perfect blastomere, you had embryo. But we went back into this patient's data. We had significant male factor. The second thing is significant number of embryos showed this tendency. At least 80% of the fertilized oocytes showed this vacuole formation at that particular moment of time, which might have a genetic role. You can also use it to look at the post-thaw of an embryo, seeing how good your thawing mechanism is there. We routinely allow the extra embryos to reach blastocyst and freeze them. And when we thaw them, we also look at how thawing is evolving and the loss rate and inner cell mass. Most of the frozen cycles will never speak about the quality of the blastomere or the inner cell mass and just say that frozen embryo transfer is done. So this inner cell mass shows a good chance. If she had good embryos in the first cycle, and in 2 frozen cycles of 1 or 2 embryos, she had good inner cell mass, I would start looking at the uterine cavity. I would look at immunological causes and start reading that area, because now I know that this area is perfect and we are missing certain areas. It's like a game of puzzle which is adding an extra dimension for you to answer the puzzle. The essential role is to deselect the other embryos and select the best embryos to reduce the time to conception. Especially as women age and the time is coming to a thing, if you're planning a pregnancy between 35 and 40, a pregnancy loss will set them back by 6 months to 9 months. A failed multiple embryos of a single cycle will set them back by 6 months to 9 months. So the deselection process will reduce time when time is precious and aged women are coming in. And the emotional trauma of failure, because in IVF and unlike other fields, the grief responses of an IVF cycle is like death. So there's no rationality, because when death happens, we don't have rationality of understanding things. That will reduce some of this information. The benefits I've seen is it has given me new knowledge, it has given a stable environment, the mix-up issue will not be there, and it's given me a tremendous insight of the many unknown facts that will be unraveled by many people around the world. The other thing is an improved embryo selection. Finally, when we move for a technology, it may not increase the pregnancy rates, but it will make things safer for the couple and make us make less mistakes. So in the process, we overall do a better job. And we are more convinced with this into 100% time-lapse monitoring, which is providing me a tremendous insight. I thank one and all for the patient hearing. I think all of us are exhausted. So you do the closing session.
So thank you everybody. Thank you Chairperson Dr. Ramaraju sir for his valuable insights both pre and during the meetings to make this a grand success. All the speakers for the wonderful presentations, and last but not the least the audience for a valuable contribution during the discussions and the patient hearing. Both the in-ground as well as those attending online, I thank one and all for their contribution. And finally, I request to kindly fill in the feedback forms which have been kept on the table. This will help us to evaluate ourselves further and improve us for the future meetings. Thank you very much. Thank you. No, please have your lunch. Thank you.